cardiographer can see the furrow, so you know exactly what's going on, and they know exactly what's going on at the same time. Echo can anticipate the device movement so as to provide the proper view. So you have to communicate with your echocardiologist what you're doing with the device. And I believe in what we call the co-pilot model. You communicate, and you're using the same language so you understand each other. These are the basic echo views of valve analysis that we use routinely during our screening and during a procedure. The 4-chamber view, the bicommissural X-plane to LVOT, and the 3D unforced view. For transeptal access, you need the bicable view, including X-plane, aortic valve short axis, and 4-chamber. In terms of anatomy and physiology, you look at the location, extent, gap dimension, leaflet length, and calcification of the mitral valve leaflets, where the jet is, how many jets, which direction, what's the valve gradient, what's the mitral valve area, and the pulmonary vein flow. Here's an 88-year-old male, severe MR, normal EF, CKD frail, high STS score by leaflet prolapse. You can see here on the TE, this is a 4-chamber view and also bicommissural view. You can see a 3D view. You can see also using the latest software, you can see all multiple X-plane as well on the left side to see the different planes and the grasping. You can see there's a focal jet in the middle. You can see transeptal access. You need to look at the aortic valve short axis and X-plane. You can see that when we cross the valve, you can see also that you can see how posterior you are and also how inferior superior you are relative to the IVC SVC. And you can see this is the XTR clip on steering orientation. The 3D unforced view is very important to make sure in the right orientation. You want to make sure your commissures are in the horizontal, so one here and one here, so you know that when you talk about 12-6 position relative to the coaptation line, you are all talking about the same thing that is perpendicular to the grasp to the line. We've also done the clip advancement on fluoro. I think this is very important. So before you cross the valve, you go take the RAO view and you take the parallax out. And when you go into the ventricle, you maintain that trajectory so that you maintain the parallax being eliminated like this. And when you come up to grasp, you can see here, it maintains that way. So you preserve the clip orientation at all times. Because sometimes echo can show you the view and you think that you're good, but if the fluoro, the clip orientation changes even a little bit, you might not be able to see it on echo. Here's the grasping with the XTR. You can see here, you need to do the bicommissural X-plane. When you grasp, this is the best way to do it. And you can see here, if the grasp is no good, and you re-advance and you grasp again. And you can see here, this is another view. You can see the grippers being dropped. And then the clip close. And you can see this is a residual jet laterally. The gradients was acceptable, so we went with a second clip. So you can see this is the first clip deployed, and the second clip would choose an NTR. You can see we went a little more lateral, but we preserved the orientation because if the first clip is oriented properly, the second clip should be right next to it without any change. You can see here now with the NTR lateral to the first clip, the grasp and the closure. This is 3D to confirm that there's really very little residual MR, and this is the final result. You can see this is the MR, which is really trivial at the end. You can see this is the deployment fluoro view. Very stable, no parallax on either clip, so they're aligned. Here's another example, 74-year-old female, a little bit reduced ejection fraction, previous complex mitral repair, severe COPD, not a surgical candidate. You can see here, this is the TE view. You can see at the bicommissural view with X-plane showing the cross-sectional where the jet is. So you can see there's a very complex jet, multiple jets, but the major jet is right here. You can see there's a sufficient leaflet and there's a bit of mitral annular calcification posteriorly. You can see this is a severe protruding calcium in the P2 segment right above the annulus. So that was certainly a very difficult location to grasp. So we decided to go a little bit more medial to that. Here you can see the transeptal access. We can see here the bicable view, and then when you do X-plane, you can see how it looks like. This is the aortic valve here. You can see that this is quite posterior, and then you puncture at the short axis view right here, aortic valve short axis. Here's the clip orientation. You can see we're staying away from the calcium. We went a little bit medial to the P2, A2 area, where the one of the predominant jets is. See the device MR assessment. And you can see here what we do also is to look at the MR and the leaflet excursion adjacent to the clip. You go a little bit more medial to the clip. You go a little bit lateral to the clip to look at what's going on. And what we do is you're concerned about the posterior leaflet insertion and worry about SLDA. You would look at the before the grasp, measure the leaflet, and then after the grasp to see what the residual length. And you can subtract the two and to get the residual, the insertion length, and you want to make sure it's adequate. So typically 6 millimeters for the NTR and 9 millimeters for the XTR. Here's the grasp on 3D, and you also want to use 3D with color to see what kind of residual jet there is. And you can see here the final result, mild MR, with a V wave went down 35 down to 22, then the gradient up to 5, so with a very acceptable result. And this is the final result as well here. You can see also the pulmonary vein flow normalized before compared to before the clip, which is blunted. Here's the Fluoro Sequence. You can see here initially we're a little bit too lateral, so we pull back and went a little more medial, and you can see this is the final result. Here's a discharge echo, looking at really mild MR, almost trivial. Here's a third presentation, 71-year-old with an unusual pathology with HOCM and systolic anterior motion, SAM, and severe MR. Very high-risk surgical candidate. You can see here was frail with Hep C and HIV. You can see here very long anterior leaflet with LVOT obstruction and severe MR with a gradient, an LVOT of 87. You can see here we do a transeptal puncture in the same way, but X-plane from the bicable view. You can see the bicommercial X-plane on the MitraClip XTR, and as soon as you grasp, you can see there's no more LVOT obstruction, and the MR significantly reduced, and the gradient come down as well. This is the 30-day follow-up, mild MR. You can see only during Valsalva did the gradient go up, but the patient is not really ambulatory, so this is a very acceptable result for the LVOT gradient. Finally, there's a 58-year-old female. You can see secondary MR, EF 15%, have chemo-induced cardiomyopathy. She's on maximally tolerated medical therapy. You can see this is a very dilated ventricle, severe MR, centrally very large jet, very high velocity. You can see even the gap between the two leaflets. You can see here again on 3D on false view, looking at there's a large gap with the very broad jet. And you can see it very well here. You can see also on the short axis, very poor ventricle function and very dilated. So again, same transeptal view. You can see here bicable X-plane to the here to see how posterior we are. You see this is the clip orientation, the left atrium and the left ventricle. You can drop the gain in the ventricle to see the clip orientation is maintained. You can see a fluoro alignment again, as you've seen before. Then you can see the leaflet grasping. It was very challenging because of the gap. So even this is XTR, it looks actually small compared to the anatomy. And you have to make sure on the posterior leaflet you don't get SLDA. So you want to make sure you have good posterior leaflet grasping. You can see here. And you can see the residual MR. You can see here on 3D, you confirm that as well with 3D with color. And so the question is, do we have enough length? So what we do is we measure the leaflet length in the left after we grasp, and we look at the lateral and medial aspect of the clip to check the leaflet length, and you can measure the native leaflet length here. And then what you can do the average and determine whether there's enough insertion. You can see there is still a jet lateral to the first clip. And so we put a second clip lateral to the first one, XTR again. You can see this is the grasping and the residual MR. You can see the again floral alignment of the second clip, the first clip. Now you have to have the proper orientation of the first clip before you do that with the second one. If the first clip is not oriented properly versus the coaptation plane, you cannot rely on the first clip during your fluoro steering and grasping, because otherwise you'll have a misalignment again with the second clip relative to the coaptation plane. This is the final result. So this is the one before. You can see this afterwards. Really remarkable. You can see again, very impressive reduction on this particular patient. You can see pulmonary vein flow improved significantly, and you can see also the V wave went from 70 down to 35. You can see her cardiac maps, and also the pressure is improved. And this is 30-day echo, 25% EF, mild MR, and she actually is doing very well. You can see again here as well. Sorry, a little bit delay in the loading the slides. Oops, looks like it has crashed. So let me just one moment. I'm almost done with the presentation actually. So let me just go back and finish with the final slide here. So one thing that we thought was interesting, you can see this is the final result before and after, is perhaps there is an annuloplasty effect indirectly with the XTR system. You can see this is before for the CC and AP dimension. And you can see afterwards the CC dimension remains the same, which is expected, but the AP dimension is reduced from 37 to 35 millimeters, suggestive of a 5 millimeter annual reduction. The next generation mitral clip you can see here is generation 4, which is 4 clip sizes to customize the repair, and also there's also independent grasping available as well. And Gen 5 is going to make it easier to use compared to even the current system. So I think the take-home message to transcatheter mitral valve therapy is evolving. MitraClip's the largest experience, and atomic feasibility has expanded, and the G4 may further customize edge repair to optimize MR reduction. Thank you.